Hi, I'm Nicole Kupchik, and welcome to 10 Minute Tidbits. I'm here with
Joel Green.
And we're going to talk today about DKA, right? Diabetic Ketoacidosis. And we thought since it's February, our little theme is how sweet it is, right? And so we're going to talk about DKA, and then our next video, we're going to talk about HHS or HHNS. You've heard it called hank, hank, and honk. At least I have since I've been a nurse. But the one we're going to focus on today is DKA, yeah. So first of all, there's been a few changes just in diabetes in general. One is, many of you might remember, we used to call it insulin-dependent diabetes or non-insulin dependent diabetes. Don't say that anymore. Okay, that's not terminology we use. I still know people say that.
Oh yeah.
Don't say that. Yeah, don't say that. It's type 1 and type 2 diabetes. So in general, what type of a diabetic are we talking about with type 1?
So type 1 is insulin dependent, which is what we used to call that. So they have no circulating insulin or very, very low amounts that don't actually, it's not functional insulin. So at that point, the patient's gonna need insulin of some sort.
Yeah. So their pancreas just does not work. Okay. So that's way different than a type 2 diabetic. So in type 2 diabetes, does my pancreas work?
Yes.
Oh, it works, but is it effective? No, not so much, right? And do you guys all know what the #1 cause of type 2 diabetes is in the United States?
It's obesity.
It's central obesity. Yes, it is. It is. And so basically, a lot of times the pancreas just gets exhausted, or the insulin is inefficient. And so what we're going to focus on today, though, is more of a type 1 diabetic who can develop what we call DKA or diabetic ketoacidosis. And so one of the things I want to say, though, is actually type 2 diabetics can get DKA.
They can, yeah.
They can, yeah.
And actually, type 1s can get HHNS, which is very rare, but it does happen both ways. So so let's just talk a little bit about DKA. So first of all, we've agreed it's usually a type 1 diabetic that is at risk for this. And again, their pancreas does not produce insulin, so they need external sources of insulin. And in general, when you think about how a type 1 diabetic is managed, for the majority of the population, it's long-acting insulin with short-acting meal coverage. However, there's, I think in the right patient population this works, but there's kind of this whole idea of an external pancreas with insulin pumps. And again, it's got to be the right patient who can, who kind of knows how to manage the pumps. But it's becoming more and more automated, where now they've got kind of continuous glucose measurement, and then in a very sophisticated pump, it can titrate up and down insulin needs. And actually, like this last few months, I've seen more of, there's a new patch app that's out where they're actually wearing a patch that embeds in your subcutaneous tissue, and it's with your phone. And so one of the HAs at work was showing me this. It basically, he can track his highs and lows throughout the day without ever actually poking his finger.
Which is amazing.
So technology is moving fast enough to make this more of a manageable condition, so you don't end up in these emergency situations.
Yeah, and I've got a friend who's got a son that's a type 1 diabetic, and it's interesting. He'll go into DKA because his tubing gets dislodged from his pump. And so lots of different reasons. So what would be, let's first of all start with reasons people will go into DKA. So what would be some common reasons?
Big things is going to be when you have insult or injury to your body. So that can be things like myocardial infarction, it can be big things like a stroke, but sometimes it can be something as simple as you catch a cold or you have the flu.
Yeah, and actually infections are one of the most common reasons patients go into DKA who have type 1 diabetes. And in fact, I've heard a lot of patients say, I knew I was getting sick because I couldn't get my glucose down.
Yeah.
Very common.
Trauma is sometimes an incidence. Patients will experience trauma, whether it's physical or burn trauma.
Yeah. Another 20% of all ED admissions in DKA, it's their first time. So it's their first time they're discovering.
It's when they get diagnosed with their type 1.
Yeah, and peak age is usually about age 6 to 11, 7 to 11, right in that range. So what would be some other reasons patients would go into DKA? Pancreatitis might be.
Alcoholism.
So
use.
Binge drinking, binge eating. And I will never forget a woman I took care of, I think it was about a year and a half ago, who was on vacation from another country, and she just got really off her schedule and ended up in severe DKA with a pH of 6.9.
Wow.
6.9, and she ended up unfortunately having to be intubated. She did fine long term, but it was very scary for her and her family. I mean, here she is in another country century, with a DKA and ICU admission on a ventilator. So it can be very scary.
Yeah, it is. It's an emergent situation. So that's one thing that's really important about it, is that when it is recognized, we treat it emergently, both the reason and cause they went into it, as well as the DKA itself.
Yeah, and I think that's a key thing is you've always got to ask yourself why, because a lot of times you are dealing with an infection or sepsis, maybe even septic shock on top of it. So, okay, so what would be some classic symptoms that patients have with DKA?
The one that always pops up is the fruity breath.
Yes, acetone breath. Yeah.
And it's even like our community members, that's something they're picking up on, whether it's the police officers, the firefighters, Medic 1, those type of people. Their first responders are actually picking up on that, as this may be a reason why the patient's not 100% on the level of consciousness game.
Yeah, because I mean, you can look drunk, but altered mental status is one of the symptoms. And if you don't know that patient, don't know they're type 1 diabetic, you might misinterpret that for maybe some, taking some sort of a substance.
A stroke or a substance.
Yeah, stroke. Oh, it actually, many times they do look like they're presenting with stroke.
Because they can have the weakness and lethargy as well.
Yeah.
The polys pop up too, which is the polyuria. They're peeing all the time because of their hyperosmolar diuresis. Their polydipsia, the polytherapy. I was going to say polyphagia, but it's polydipsia.
Polydipsia comes next. Yep.
So
their thirst center is really activated because they have this massive osmotic diuresis, and they get very, very thirsty. And then the third P is polyphagia. They're super hungry, right? Yeah. They're in ketosis. And if you think about, what is the stature of somebody look like who is a type 1 diabetic who might go in and out of DKA? Are they heavier or are they thinner? And in general, they are thinner because they're fat burning very frequently. Okay, what are some other signs?
I'm trying to think of what else.
Temperature regulation. Yeah. So temperature regulation can be very challenging. We already said altered mental status.
Weakness,
they're super dehydrated. I think we've mentioned a lot of them though.
Yeah, I think those are your general assessment. And then from there, after you've figured those assessments, it's probably your lab work.
Oh, absolutely. And so what kind of labs do we want to focus on?
So with ketoacidosis being in the title, your pH is going to be one of your key giveaways is your diagnosis. Whereas HH&S won't have an acidotic state, DKA is going to have pH is less than 7.3.
Often. So acidosis is one of the key things. Their bicarb is going to be really low. What about their CO2? So think about this. If you're breathing fast, where they've got that Kussmaul's breathing, what's going to happen to their PA CO2? They're going to blow off their CO2. So if you measure that in end tidal or in a blood gas, it's going to be really low. Okay.
Which they're going to be, it's a weird state because they're going to be in a metabolic acidosis from the DKA, but because they're breathing off all their CO2, they're uncompensating as well. So
So it's like they almost get like a secondary respiratory alkalosis from the tachypnea. Okay, and then let's see, what other labs?
There's serum osmolality.
Oh, osmo. Let's do osmo.
And I always want to call it osmolarity, but there's osmolalities, which basically shows you how dehydrated you are.
Yeah.
So when those levels are greater than 300, you know that your patient is super concentrated serum.
Yeah, and so a normal osmo is 275 to 295, and the little rhyme we always use is if the osmo is high, you're intravascularly
dry.
Yeah, so high and dry is kind of the lab we always, with osmolality, it's the way we always think about it, but often they're going to be above 300, okay.
Then we have Anion Gap, which is your electrolyte balance, which is your sodium, potassium, chloride, and bicarb.
Yes, and a normal gap is about 11-ish.
Yeah, 6 to 11, somewhere in that range.
Yeah. And what do you see with a DKA?
You'll see them on the high side.
Yeah.
So whenever you have a high anion gap and you're metabolic acidosis, then you can start going through some of the different acronyms for why you're in that range. So.
Yeah, and the acronym I always teach, if you've been to my class, is MUD piles, right?
Mud piles.
MUD piles. So
I forget what the other one is, but it's the mud,
Yeah, MUD piles. That's what I teach, but it's methanol, uremia, diabetic ketoacidosis, propylene glycol.
I don't remember the other ones.
Isoniazid. Let's see if I can get through it. Isoniazid, lactic acidosis. What is the E? And salicylate is the S. Mud piles. What's the E? Okay, you guys you can make fun of me right now. Yes, thank you. Yeah, I was gonna say, oh my gosh, everyone's gonna make fun of me because I teach this all the time, right? Yeah, but you're gonna always have a metabolic acidosis associated with it, and then you just gotta figure out why. And then obviously DKA would be a big reason why. Yeah. So you probably have heard that term close the gap.
Close the gap, yes.
And what they're talking about is the anion gap. It's going to be very elevated, and you need to close the gap or normalize it.
Yeah.
And a normal, again, is how much?
6 to 11.
6 to 11-ish, okay.
Potassium, glucose, and phosphate are also going to be out of whack in these types of patients.
Yeah.
And that's always a fine balance, because the first thing you want to do to give these patients, you're seeing a blood sugar of 300, you want to give them insulin.
Yes, you're like, give them insulin. However,
but if they have a low potassium, that's the last thing we want to do right out the gate.
Yeah, you've got to be super careful. And I know a lot of times I'm really cautious if the K is less than 4. I'm like, I don't know if I'm ready to start my insulin. I'd rather, like, it depends where the K is. If the K is less than 3.5, you cannot stop your insulin. You can't. You've got to give K and get the potassium up. You know, but even if they're 3.8, you've got to be super cautious. 3.8, 6, 7, 8, 9, under 4, you've got to be really careful, because as soon as you start the insulin, where's that potassium going?
Potassium's going to shift to the cell.
To the cell.
Yep.
Yeah, and then you can end up with a super low potassium before you know it, right? So you got to watch your potassium really, really closely. Now, one of the things that drives me nuts is when I get an order for K-oxalate, and I've got a DKA or an K of like 5.7, and you're like, we're not giving K-oxalate. No, because as soon as
going to shift. As soon as you start the insulin, it's going to drive in. So you need to wait until you get sugars down before you can make that assessment.
And then you've got a mess to deal with K-oxalate. Just don't do it. Okay. All right.
And then phosphate is one of the weird ones.
Ooh, yeah.
Because
low.
It's going to be usually low, and so people want to treat it. But the problem is you're going to get hypocalcemia if you treat it in these patients. And one of the reasons it's so low is because you're using your glycolysis instead of your citric acid cycle to maintain energy.
That sounded so nerdy just now.
I know, it's the Krebs cycle, and you're like, oh god, I can't remember it. But when you're in metabolic cellular respiration, you're making very low ATP, but your body has to work so hard at it. That's why our phosphate's disappearing. But once you switch back to a normal cellular respiration, then you get your phosphate back.
Yeah, and in general, what the guidelines say, so the ADA guidelines say to only treat the phosphates less than 1, but otherwise you don't really aggressively treat it. So, all right, the other big electrolyte, sodium. Sodium often, it can go either way, but often I see it diluted. So you might see a hyponatremia, but it's the glucose that actually dilutes the sodium.
And what is it, for every 100 deciliters it goes up, your sodium's down by 7 or 8, something like that?
Yeah, it's right around there.
So if you're looking at a glucose of like 400, your sodium's probably off by about 14 or 21 milliequivalents.
Yeah, and again, I think with electrolytes in general, potassium's just the one I'm really freak out about if it's low. But in general, you just kind of see how things shift out. You get, so first of all, let's talk about treatment. What's your number one priority in treatment?
First and foremost is volume.
Fluid, right? You've got to give fluid. And so we usually will start with like isotonic.
Yep, so this is going to be your normal saline, your lactated ringers. Just a key pearl, remember that D5 is only isotonic for the first little bit, but as soon as that dextrose gets metabolized, then it becomes a hypotonic solution.
So be careful. Yeah, super careful. But yeah, we'll start out with an isotonic. And one of the things your providers should be doing is calculating what they call a fluid deficit. There's a calculation you do, given a lot of your labs, to see how many liters behind are these patients. And in general, in DKA, you're usually minimum 5 liters behind. Minimum in DKA. So I know I've had patients that were, the one lady I was telling you guys about, she was 12-liter fluid deficit with DKA. So it was...
And you're doing about over a liter an hour when you're resuscitating them. So this isn't just the 999 on the pump. These first couple liters are probably pressure bagged. And in the first hour, usually you give about 1 to 3 liters, but you've got to be careful too, because everything's shifting, and especially in kids, because if you resuscitate too quickly, you can actually cause cerebral edema. But in general, that first hour, you kind of load them up, and then you start to back off, and you spread out the fluid over about 8 to 12 hours. So. And then you're going to start your insulin once you know your potassium stabilized. And then with your insulin therapy, just watch and careful, because once you get to the 250 mark, that's when you need to start adjusting fluids again. So now that we've hydrated the extracellular space, we need to hydrate the cells themselves and switch over to an isotonic. So something like D5.5 with potassium is usually kind of the realm that they're looking in treatment guidance.
But in general, when your glucose gets to about 250 or below, add some dextrose back into the IV fluids to prevent hypoglycemia.
They need a substrate, something for energy.
Yeah. And then kind of a last step in fluid resuscitation is hydrating the cell. And that can happen one of a couple ways. You can either do it with like a half normal or just let the patient start drinking water, right? And they can kind of do their own cellular hydration. Because remember, water is hypotonic and it will go to the cells. So, all right, what are some other pearls? Any other pearls? Don't correct glucose too quickly. Right. That's a big pearl.
So you don't want to go from like 400 glucose down to like 180.
No, like in an hour, don't do that. Like in general, we usually try to bring them down by like 50 to 75 an hour, but really not much quicker than that. Yeah. So you got to be really careful. Okay.
And then you have to decide at what point are you going to transition them back to subcutaneous insulin and let them eat, which is always the next challenge.
And this is but there's a couple things you have to do, right?
There's a couple keys. So one of the things we talked about earlier was closing the gap.
You got to close the gap.
So making sure your anion gap is less than 11, and then your osmoles. Make sure your osmolality is less than 300.
So kind of normalize-ish the osmolality.
So that you've got them fluid resuscitated, you've got their gap closed, their electrolytes are managed. That's kind of your key turning point for when it's okay to make the switch back.
Now, if you're going to check ketones, like let's say we're at the point where we're trying to decide, is it ready to transition to their kind of long-acting insulin, should we check urine or blood ketones? The answer is blood. You should always do blood because you're going to continue to spill ketones in your urine far beyond the point that you've shut down ketosis.
Because your kidneys are still filtering all that out.
Yeah. So close the gap.
And tighten it and get your osmos back under control, under 300.
Shut down ketosis. And then we're going to fix or try to normalize the acidosis or the pH. So I think those would be the main pearls.
Yeah. The other thing too with the acidosis that I just remembered is bicarb. Remember that bicarb's on a national shortage still. So it's one of those things. In some of your hospitals, you've probably noticed that it's no longer in Pyxis and free to give away like we used to.
So should we stop pushing it in codes just because?
Yeah, it's one of those. Should we not just give it just because we have it? The other thing with it too is the recommendations are a pH less than 6.9.
Yeah, so remember,
kind of the cutoff.
Yeah, so you don't push bicarb just to treat numbers. You know, you give it when it's appropriate. Yeah. So okay, good. Any other pearls for DKA management?
I think that's really about it right now.
And then teaching, of course. Yeah. Oh, I know one thing I want to mention is when you transition them off of their IV to their long-acting sub-Q, there needs to be an overlap between the IV insulin and the sub-Q of at least 1 to 2 hours. Yeah. So you need to overlap. If you don't overlap, you can go back into ketosis. So that's what you've got to watch out for. So I think that's it. Those are the main pearls.
I think so.
So fluid resuscitation, bring them insulin to bring them down slow. Watch their potassium, watch electrolytes. Close the gap, shut down ketosis, normalize pH.
And they should be fine, right?
They should be totally fine.
Yeah, totally fine.
All right. So that was our 10-minute tidbit on diabetic ketoacidosis. I'm Nicole Kupchak and
I'm Joel Green.
And this is it.